numbers, it depends on how recent your data is, but we spent 11, 12,000 per person per year on health care. Now, multiple, and US population? Large. Large is a good answer, but how many people do we have counted? We just have the census done in the United States. We're pushing toward 350 million, yeah? So multiply the two numbers together, what do we come up with? Big numbers. So this says, this particular chart shows you the percent of the entire economy that is being spent on healthcare as compared to the countries that we should be comparing ourselves to. So developed Western nations. There's, Netherlands here, Canada, Sweden, France, Germany, UK, so on and so forth. We're this. Everybody else is like clustered over here as a percent of their economies. So the second highest, we spend about, this is 2018 data, we spent about 17% of our entire economy. And our entire economy is, pretty big, right? It's somewhere around $16 trillion, $17 trillion, something like that. We spent 3.5 of it on health care. So you're right, it is extremely important. The second highest is Switzerland, with about 12% or so of their economy. And New Zealand, 9.3. Now, what kind of outcomes do you think New Zealand get for their much lesser spending? Do you think New Zealanders are healthier than us in the States? Yes, they are. Okay. Now you can see they spend less, right? How do they get it? How do they get to be healthier than us and spend that much less? Any ideas? Yet? Yeah, exactly. The care is focused on preventative, right? We have to, and promotion of health and preventing diseases, and then if somebody has chronic conditions, managing those things effectively. We are not set up. Our system is not set up. How is our system set up? What as compared to many of these other countries? What's one of the major differences, just in a setup of it? What do we address in our healthcare system more than anything else? Maintenance. Yes. It is set up for maintenance, whereas we are set up for. How does our healthcare system work? Ever seen Grey's Anatomy? Right, we fix the problem, or we try to addressing the problem after it already happened, right? Whereas everybody else works very, very hard and spends a lot of money on preventing that problem from happening in the first place. Much cheaper, that proposition, versus than what we do. Fixing it when it already happened, or trying to address it when it's already happened. So it's a reactive healthcare system. It is not, it doesn't have, proactive care just absolutely, virtually. It exists in some places, but it virtually is non-existent. And nurses are not focused on proactive care. Everybody else in the education system is set up in a way, everything, our entire country set up in a way that educates around reactive stuff only. And again, we're doing something different here, and the reason for it is just, that first slide. Is unless everything changes, what nurses learn, where they practice, how they relate to the population, nothing is going to change. We're going to continue spending out of control. This is the spending per capita. Again, New Zealand, right around $4,000 per person. that lives there. And in New Zealand, everybody who needs it has access. And everybody participates in preventative stuff and so on. So 4,000, here we are. And this is the 10,200. And the data is from 2018. So a lot. And public spending, meaning taxpayers' money, about 5,000 per person. Private spending, meaning like employers normally, another 4,100 or so, and then another 1,100 comes out of the pocket after the premiums paid and all of that. So, yay! Woo! Winning! Fantastic. All right, so let's talk about what we actually get for all this money that we spend. Let's talk about our outcomes for real. So what kind of outcomes do we get in this country, health-wise? Come on. Wakey, wakey. Anybody needs coffee? Those of you who partake? It's right there. Right. So our outcomes are not good. We have established that. For the amount of money that we spend, we should be like the healthiest nation on earth. All of us should be happy, peppy, completely healthy all the time, going around doing cartwheels and, you know, contributing and flourishing and doing all of that. Far from it. So let's talk about big health outcomes. What is the largest health outcome, the biggest one that any nation can have? How is it measured? How is healthy life measured? In what? Lifespan. Absolutely. It is measured in lifespan. Now, so here's, I'll show you. Life expectancy. This is everybody else. This is us. Just take that in for just a bit. Yeah? 78.6 average. The developed world, OECD, average is 80.7, and that's just the average. We are at 78.6. Sweden, with spending, you know, second highest, gets 82.5. Sorry, Switzerland with second highest gets 83.6. They have the highest life expectancy at birth, right? And those 5 years make a huge difference. And in those last 5 years, we spend a lot, the last 5 years of our lives versus anything that's spent there. Because people arrive to that age much healthier, right? We need new hips and everything else. Okay, so again, the kind of the largest, the most kind of prevalent health outcome, and see how it slopes down a bit lately over the past decade? Yep. We are trending in the wrong direction. Whoopty-doopty us. Yay. Okay, other health outcomes. What else? What contributes to life expectancy? There's one really important indicator that contributes to life expectancy. Again, that we're winning, unfortunately we're winning in, negatively contributes to life expectancy. Oh yeah, we'll get to that. Obesity, yeah, absolutely, and all of our chronic conditions and all of that. But what? Maybe. I mean, okay. So this is not a great statistic. You know, French are almost there. So suicides. We have the highest rate of suicide in this nation than any other developed country. Quite a bit higher than the average. And this is per 1,000, 100,000 of population. Okay, so what else? You already said obesity. Key answer, yes, true. What do we call all of that altogether? All of those conditions. Comorbidities, yes, okay, that's good. By the way, Martin, if you can throw that question, and it's a trick question. U.S. ranks the worst in which of the health outcomes? All of them. I mean, that just, we'll throw that question in just for you guys to show you engagement out there, but we're absolutely winning on the bottom of all of it. Mental health is part of it, yes. So what is all together? What is it called? Those conditions that you're describing. Obesity, diabetes, chronic. Yay! We got there. Boom, that's us. On that side, 28%. This is percent of the population, of adult population. 28% of all adults have more than one chronic condition. If you add the others in with only one, we're pushing 50%, half of the population. Wow. Yeah, and see how everybody, 14, 15, 17. And then Canada, you know, neighbor to the north, they're trying to catch up. Absolutely. So there's many factors, and we'll talk about the factors actually that contribute to all of this here, you know, in a bit. But it's an important point. Absolutely. Because we are reactive, because we do nothing, and look, chronic conditions, only a small fraction of them comes from kind of genetic stuff, genetic predisposition. There's some genetic markers that, you know, certain genes that fire and then create this chronic condition. Most everything else is absolutely preventable. Like, what is the number 2, like, chronic issue in the United States? Diabetes. And what most of the diabetes that we have is what kind? Type 2, which has nothing to do with your genetics, have everything to do with your lifestyle. It is a self-induced chronic condition that is absolutely preventable and absolutely avoidable. Type 1 you can't avoid. That's just your hardware is not working very well. But type 2, absolutely. Now, what is number 1? Heart disease, the number 1 chronic condition in the United States. Very, very few cases are, again, genetically caused. Everything else is lifestyle caused, right? And is absolutely preventable. And can be so much cheaper if it never happens. Yeah? And so this obesity that you were talking about contributes to that quite a bit. To heart, you know, the heart just can do what it can do. You know, that muscle can, you know, and when it can grow. It's not good when it does, but you know, to pump blood to more and more tissue, that appears. Okay, so that we're here. Okay, speaking of, yay, winning. Obesity, 40% of the US population are clinically obese. 40. That's 4 out of every 10. These statistics are mind-boggling, and again, Switzerland, they still pay, you know, they spend like not as much as we do, but they do. But look what they get for it. highest life expectancy, lowest rate of obesity. We're 3 times more obese than Switzerland. I mean, it is, if you start really digging into it and looking into it, and then what did we say in the beginning about health? It helps our economy. It does all sorts of wonderful things when it is present. Ben?
You got about 300 learners online watching this that are dying from you saying winning, so just want to keep you updated.
Oh yeah, winning! Yay. I was like, who am I? Is it what's his name, Charlie Sheen? That said it a few years back. Winning. All right. So yeah, look, it is, we can, when I look at this, at all of these statistics, and these statistics publish pretty much, this report that the Commonwealth Fund publishes, like multi-nation comparison of systems, healthcare systems, health outcomes, and all of this. The last one they published in the beginning of 2020, and you know, the next one likely is coming in about 6 months, so they do it about every 2 years, and our numbers just keep getting worse and worse and worse. And they're not, I mean, we're moving in the wrong direction. Everybody's moving in one direction, and we're moving in the other. And again, there are many reasons for it, but the nursing workforce's inability to address this is a big, big contributor. Okay, what else can I share with you? Oh, well, that's just some other fun stuff. So this is physician visits and physician supply. U.S. supply. We have the lowest number of physicians per 1,000 of population. Switzerland, 4.3, doubling. Or almost doubling our number. The average is 3.5. Right? Now, visits. This is visits per capita. Average physician visits per year per capita. We're at 4. Germany is at 10. How we're doing? Not great, not great. So yeah, that is shortages. Somebody said shortages earlier, right? Provider shortages is a problem. Nurses can address primary care provider shortages, can't we? Absolutely we can. We only have to, you know, set our mind on it and drive toward it and do all of that to work with the population directly in order to address some of these issues. Because at that number and the size of our population, we're not going to get anywhere near what we need. And the supply of kind of physician education spots and so on. Physicians are not going to solve this issue in the United States, or the health issue in the United States. Must be nurses, must be you, like all of you now. And we do this with you fairly early in your program, and to get you set, your paradigm shifted toward thinking about this. That really you have to become the solution. And without you, it is not going to happen. It's just not going to happen. And we can sit and wish for a long time that, well, some magic fairy, Harry Potter is going to come and abracadabra, whatever the correct word is, and boom, solve it all for us. That the government somehow is going to, one day, the entire Congress is going to wake up and be like, oh yeah, sure, we have the solution. It is not going to happen. There is not going to be, there can be some policy solutions that should be there. We'll discuss them later. But it is not, we have taken the approach of, oh, I'll just go and vote. I'm done. Or I'll clock in, I'll clock out from my job, and I'm done as a nurse. wrong approach, hasn't worked, is not going to work. Right? Remember doing these things in the same way and expecting a different outcome? Yeah. Insanity. Prime definition of it. And yet as human beings, we're predisposed to that type of insanity. We're like, oh, I'll try again. That didn't work, I'll try again. And change nothing about the way you approach it. If you didn't get a positive outcome in your studies, for example, right? Something. You are currently offline.
You're streaming on YouTube. It's just the team, so you're still going.
Okay, I'm still going. That is good. Okay, so are you turning that off now, or?
I'm gonna keep it going.
Okay.
You just,
Continue.
yeah, I'm sorry about my head.
That's okay. It's a great hat right there, Ben. Okay, so yeah, it's our approach normally, and it's just how our brain pre-programmed to function. Is that we try something, and they're like, okay, well that didn't work. I'm going to try it again, but we forget to change something in the way we approach things. We forget to change the process that we're utilizing in the system that we use in order to get to a different outcome. And that's the point. And we've been trying this, what we've been doing. Gosh, I mean, we've been trying for too long, and we've been getting the same outcome, and the outcome's just becoming worse and worse and worse and worse. All right, the hospital acute care, average length of stay. We're somewhere in the middle, right? Below average, though. Now, with our health issues, you would think we probably would need more. Yet we kick them out, cross our fingers that they're not going to be back in 2 weeks. And they are. A lot of them come back, right? Because we haven't, we tried addressing it, but we haven't addressed it fully in the first place. So again, what else? What else I got for you? Oh yeah, we actually, MRI exams, our diagnostics are on a higher end. Now we'll talk about that as well in a minute. Oops. Oh, hip replacements. Oh yeah, didn't I tell you? We like our new hips. We're there. Immunizations. We actually, so this is one of those things where we're not doing that bad. We're actually leading out on the breast cancer screenings. So breast cancer, we address, we figured out that, you know, the earlier you figure it out, the earlier you detect it, the less problems there are, and the more effectively it can be addressed, and people can be in remission. Now, and our immunization for older adults, this is just flu, is quite high as compared to others. So we are not the worst in absolutely everything, but this is just one of those rare glimmers of hope. And because we do this immunization thing, we do have, we prevent quite a few deaths at an older age because of the flu. Okay. And this is the breast and cervical cancer survival rates. We're leading in that. So when it happens, and when it's detected for breast cancer specifically, and cervical too, we do Pap smears. We try catching it early, right? So again, our survival rates for breast cancer is this is the breast cancer is really high. Cervical though, we're at 63, so not as fast. Oh yeah. Diabetes and hypertension. So the green line is diabetes, and this is hospitalized diabetes cases, and hypertension is in the other. The average is right here. Whew. Oh my goodness. The next one is sad as well. Mortality amenable to health care. What does this mean? Preventable deaths. Exactly. Like people didn't have to die because we could have prevented it through effective utilization of the healthcare system. Winning once again. So as you can see, at 2016, everybody in the world has improved, but whoosh, that's us. Everybody's improving. We have improved, but not quite as dramatically as, for example, Norway. They cut it in half. 16 years. Okay. So, just to summarize. Ta-da! I'll read it out to you. Mortality amenable to medical care, highest. Infant mortality, highest. Life expectancy, lowest. Suicide rate, highest. Obesity rate, highest. Prevalence of chronic conditions, highest. Then cost-related healthcare access problems were last in. What does that mean, cost-related access problems? Right, those who cannot afford it, who need the care but cannot afford it, and therefore end up not having it. That's again, we're the less our healthcare system efficiency is the last. And healthcare equity, as we discussed before, across all of these countries. We spent the most, 3.6 trillion in 2018. It continue growing. 30.7 million uninsured, which is a tenth of the population. We spent close to 18% of the gross domestic product that year, and the spending in healthcare always outpaces the economic growth, right? So the economy is growing at a very modest amount when contractions are not happening, and healthcare keeps expanding at very high pace, even through economic downturns. 2008 and that recession, the Great Recession, was a prime example of how everything is contracted. The economy just, essentially continued not only not expanding but slowing down, and healthcare was well and alive, growing by 4 to 8% every year. Yay! So yeah, unsustainable. We're just absolutely unsustainable in our health. In our healthcare. So another question, Martin, are you ready for it? Oh no, not yet. Okay, so let me see, on time, we're doing all right. We're gonna have a break in about like 20, 25 minutes, so hold it, yeah? This is nursing training. Patients come first. Hold your bladder. Okay, but seriously, if you have to like step out, go before then. Okay, so this slide shows the essentially who pays for healthcare. You know, that $3.6 trillion spending in 2018. This is who paid for it. So this is payors, meaning the people who support, who dish out the money, or the organization who dish out the money. So the Medicare and Medicaid combined outpace, obviously, government spending outpaces everything else. As if you add them together on the federal side, Medicare, and then on the state side, Medicaid, it continues growing. What is remarkable, if you look at this slide, do you see anything remarkable on the slide? What kind of like, it's in your face right away? Anything? Well, out of pocket is a lot. Yes, it's a 10% of the total, about. The what?
Private insurance.
What is remarkable about private insurance versus Medicare or Medicaid? There's something that is there that is kind of like, yes, thousands of dollars less per person, per enrollee. Medicare spends close to $13,000 per person who's enrolled. Private insurance spends less than half of that. Why? Come on. Why does that happen? Think about it. Think about it. Why is Medicare spending so much more per person than private insurance?
People in Medicare will go when they have an illness versus a private insurance to get preventative care.
Okay, so perhaps the types of care, although Medicare pushes preventative quite a bit and effective management of chronic conditions quite a bit. So it could be. It could, utilization rate itself is higher. Now, Medicare doesn't cover the entire cost of whatever it is care that somebody seeks. Medicare only covers 80%. So there is still an out-of-pocket cost to that. So, and some people may not utilize, although the rates are better, the kind of negotiated provider rates are better with Medicare. Why, like, what is the biggest reason, though, that there's such a disparity between the two numbers, the almost 13,000 and barely over 6,000? Yes? The what? The third party? Yeah, it is, but what's absolutely different between the populations served? Yeah, who are the people who qualify for Medicare? Older people. Yeah? We already determined that the older you are in this country, the worse you are doing. So, and everybody, now, anybody who says we don't have universal health care in this country mistakes, because we do, but only for a certain group of people. We enroll only the oldest and the sickest into our universal insurance coverage. Yay? Okay, and who enrolls in private? Working people, right? Younger, less problems perhaps. Less that. So we'll talk about that a bit later. A little more of what. Okay, so, but who sponsors? Who sponsors? Right, this is who pays, right? Obviously Medicare doesn't have its independent money. Right? Everybody understands that Medicare as a governmental agency has to get the money somewhere. Where do they get it? Taxpayers, absolutely. So let's break this down. Who sponsors health care? 28% households directly. And that number is only the premiums themselves and the out-of-pocket cost. Households pay for close to a third of the entire spend. So you and me. Now, you add this next one that says federal government. And federal government gets their money where? From working people. Let's just, you know, not from Amazon. For people who work for Amazon, yes. And state and local. Where they get their money? Taxpayers. So when you add all of this together, that, and that, and that, what do you come up with? I'll let you do quick math. Public math. Come on, let's go. Let's do this. Public math. 73%. That is correct. Three quarters of the entire $3.6 trillion in 2018 was paid by people like you and me. Obviously, it depends on your income and how much, proportionately you pay and all of that. But so anybody who tells you on whatever channel it is that you're already not paying for it, wrong. You absolutely are. Everybody understands that? Tidbit piece of it? Fantastic. How much are you getting for your spending? What outcomes? Not great. Don't you think we deserve better? Yeah, nurses, that's right. Let's start figuring this one out of what to do. But keep in mind that a lot, if you take 75% of $3.6 trillion, that's about what, 2.5 or so? A little more trillion comes from households. Already. It's already there. We just don't see it as, it's not in your face. Okay. So what's that question? Oh, yeah. You can throw, Martin, you can throw that question and see if people on Teams have been paying attention, because I already given them the answer. Okay, how much do government entities spend on healthcare? Okay, and then finally, let's look, where do the dollars actually go? Hospital care, 1/3 of the entire spend. $1.2 trillion on hospital care. $1.2 trillion on hospital. What do we treat in the hospitals? It is acute care, but what do we treat there in the hospitals? What do we spend the most of our money on? The what? Yes, on it, what ends up, so the system itself, the acute care system, right? The problems are acute, but they are brought on, in the vast majority of them, by exacerbations of chronic conditions. Which again, these flare-ups, these acute episodes within chronic conditions are absolutely preventable. The vast majority of them. It doesn't have to get there. And yet look how much we spend reactively to fix it. $1.2 trillion. A lot of money. And then you have, other things. Prescription drugs. $335 billion. Congratulations. We're like a pill-popping, loving nation. There's a pill for that. That's great. Who cares what I do, because, I can pop it later. So that is quite remarkable. That's the second highest spend category is the prescription drugs. And then you have all sorts of other things. Don't spend anywhere near on nursing care facilities, continuous care, retirement kind of things. Like, who cares? They'll be dead soon, right? What? Think too much? Yeah, why bother? Why bother? And dental. There, other professional, which is all of your physical therapies and all of your, care that is not acute, goes there. Personal care services, so on. So yeah, that's the picture of it. So let's summarize where we are. How are we doing? Bad. Look, it's comparative, right? If you compare us to some, developing countries in Western Africa, we're fantastic. We're amazing. Probably not the right comparison group, though, right? If you compare us, the US, to our rightful comparison group, other developed, rich nations, we are the worst. We get the worst outcomes. We have I'll tell you this, I haven't mentioned this one. We're about number 47, 47th in the world, 192 countries. There's only the developed countries, probably, the top 20, 25 perhaps of those. We're 47th in maternal mortality. 47th. Women dying during pregnancy or during childbirth. Mind-boggling. So again, I want this for all of you in this to kind of sit with it, process it, reflect on it as we go. We spend so much money. We spend an inordinate amount of money. If you start writing out $1 trillion, it's zeros that never end. Like million we kind of understand, like 6 zeros and then a 1 something in front of it. Trillion is just to play with it. Just look it up. Just, show me, ask Google to show you a trillion just written out with 1 and a zeros. It is mind-boggling, and it's really, really, I don't want to be like judgmental on us as a nation, but it is shameful. It is absolutely shameful of how much we spend and what we get. And so, and the reason it is this is happening is systemic, right? The reasons are big. The reasons are, in order to address this, again, nursing as a profession will have to do something very, very different and very, very quickly. How many nurses do we have in the United States?
4 million?
Yes, 4 million. We're approaching 4 million nurses, licensed nurses, right? So this is between RNs, which comprise most of those, probably close to 3.5 million. And then you have another about 500,000 or so, or depending again on which counts you look at, licensed practical nurses, licensed vocational nurses. Again, you would think with let's do some math with 4 million. What percent of that of the U.S. population that are actively licensed nurses? It's a large percent actually of the U.S. population. It is more than 1% of the entire population of this country. Now, which means 1 professional nurse to every 100 people. That's not that many. That's not that many people to address for 1 nurse, isn't it? No, it is not. How many friends do you have on Facebook? Yeah? More than that, I'm pretty sure. Like, we're friends, we're like this. Fantastic. So we'll talk about, after the break, we'll talk about what it is that we have to do as a profession, as individuals in a profession, collectively in the profession, in order to this unsustainable path of unhealth and this inordinate amount of spending to bend for at least not to be growing as fast, right? Bending that trajectory. So let's take about 10 minutes and then come back, stretch your legs and all of this, and we'll continue. 10 minutes, everybody. Be back because there's a question coming right after the break, which, engagement will be measured by. Yay! Okay, go for it. Something either here or there.
Yeah.
Oh,
But there's a 35-second.
Yeah, on YouTube there's a 35 to 50-second delay, and it's changed all the settings. So
Who's pushed one?
So if you ask the YouTube audience question, I see it here 20 times.
yeah.
From the team.
That's why I'm kind of like I'm going through it and then just throw it in and whether you paid attention. Tell us you did.
The comments that are they come through so fast.
Oh yeah.
They're really enjoying it. Good. Also, your mic's still on, so don't say anything embarrassing. Just leave it on.
Oh, I did turn it off.
You turn it off? Turn it on.
Hello, testing.
Yeah, okay.
Okay. Can I turn it off now? No? I'll leave it here then. I'm not, yeah, because you know.
Fred and I are doing all the swearing back here, so you're totally fine. You're supposed to tell me to take my hat before we started. Now it's too late. I'm gonna be jailed. Okay. You weren't supposed to tell that.
Six and counting. 6 cups of coffee and counting.
Yeah. I really just live off of coffee and shit just.
Oh, somebody said that.
They said, amazing how much nursing director is and how that is directly affects whether they live there.
I'm so glad we're in person.
Yeah.
I guess
That's
Jessica,
exactly what we want here.
another job, she's in Flint, and she's like, we should not hear anything from this case freaking out.
Oh, really?
So, so
How do you know how many pages we have to write?
I don't know.
got the screen a little like the while you
Those are gonna eat all. If I had the internet.
so awesome. Just be like your definition of awesome. I think that was actually the most well, last night I was like, everything I can do that it works great, like the audio,
Well,
like maybe there's
if you attended it,
everybody's
when
like
you're present. If you're not, you have to block.
like maybe there's something I'm missing and that no fix it.
Right, but I think we have to write comments because I saw like in the grade book.
Well, it depends on which camera I'm focused on. Right now, for some.
Yeah.
I don't know.
What did they put in that?
What's that?
There's a paper due for this.
Yeah. Do you know how many
I mean, I
pages
didn't really read
we're
this.
supposed to write on it? I wonder if they're gonna give us like more details or I just missed something. Do you know how many pages we're gonna write?
I don't know, so one of my classmates said that she wrote 6 pages, so I don't know if you have to do that much, but
Well, I was thinking 15, so that's good.
yeah.
So it looks like
Oh,
was the same questions.
Yeah, maybe we have to refresh it like on like the questions with
what?
importance and you know the papers as well.
So for impact statements, they come up with 3 peer-reviewed sources.
smart.
glad you're here.
Yeah, Martin is going to send them after, so I'll repeat that as well.
So, minimal control for to answer the questions.
Yep. Well, yeah, that's
So,
what I'm saying, you know, like, one,
It was less accurate. I thought about it and I was like, no, it's not accurate anyway.
good speed test and just say, okay, like, we're venue, let me see what it is. Yeah. Right, let me see what it actually is. Yeah, you have to offer at least 50, right, and it's like, it's done. Great, I mean,
Yes.
okay.
you win, and then, yeah, so,
Yeah, 'cause that's,
yeah.
But I wanted to use it.
Oh, no, we can't.
Always recorded.
And didn't we go decide, I think we decided to go like to not Littleton, but go to like Denver, Metro Tech or something like that?
But it's, circuit.
We have until
It's not in Littleton, it's like.
with everything else.
Not to rate on that parade or anything for you, but
Not enough for me. It was either more like extend my graduate time or just suffer, and I was suffering. 2023. Yeah. Okay.
that's hard.
When's your graduation day?
Because I don't have to do it.
Yeah. It wouldn't be so bad if I didn't.
Rick was talking about, like, something in that area.
Get through it. Can't really remember any of it ever again. Shit. Heather, what's that was done? Deuces. Any of it?
So like, yeah. No, I'm really sure.
Yeah, I'm literally trying to survive that class. Like, I forget everything but week after, which makes it, like, really hard to figure out again.
But yeah, if you do it like
So I made it to week 9.
more central, then.
I'm going to, it's 9, not big one.
Much lower quality. And it was cheaper.
Yeah, this is like,
Oh, yeah.
it takes me like 8 hours in one sitting.
All right. Ready? Oh, yeah. Oh, yeah. Okay. Microphone. That's right.
You should do that. Our whole community. Confidence in him.
All right. Right, ready, guys? Ladies? Let's do it. Let's talk about some of the... Okay. Martin, whatever is the after break. Are we on, Ben? All good? Everybody back? Come back. I see some comments popping. Awesome. The whatever the after break question. You're sending that in? I don't know what it is. Anyway, it's the I'm here. Okay. So now that you had some time to process this, let's talk about why. Because without figuring out why what we discussed is happening, okay. Without figuring out why it's happening, obviously we can't really come up with any solutions or sound solutions to fixing it. Everybody agrees, though, it needs to be fixed, right? Everybody's with me on this? Yes. Okay. Yeah. I've been. As soon as I started practicing in the States back in the mid '90s, I was like, ooh, this is not like home, or old home, and it something needs to be done about it, and so we've been doing it. But why? So let's talk about the reasons why. Why do we have such high spending with such poor outcomes?
We're not educated enough on physical exercise and nutrition, and we're just getting pills to fix it.
Right, yes. The number one reason is that we're so just completely, we completely disregard the lifestyle, how lifestyle affects our health, right? We're not educated really, truly on figuring out how to keep ourselves healthy in the first place. And how to, and yet, we have plenty of information out there, and yet again, it's just not penetrating into the population as much as it should. So yeah, so let's talk about the lifestyle a bit. What's our lifestyle? Yes. Right. That would be a good idea, right? But we're not. We're not eating healthy. We're eating fast foods. We don't exercise. As a matter of fact, we don't move. Yeah, it's just like this all the time. So yeah, nutrition is constantly disregarded, and yet poor nutrition is what creates the vast majority of those chronic and lack of movement, really lack of what humans need biologically, just doesn't exist throughout the population, and that's what we consistently forget, and we kind of brush it off that oh no, that's not what's making me or will make me ill or chronically ill at a certain point. No, it's not going to happen to me. Now it's like, it looks like awesomely cool. Yeah. It's like, could double for, Mother of the Dragon's babies with the, but yeah, looks cool. Not good for you by any stretch of imagination, right? Inhaling all sorts of chemicals one way or the other. And yet again, so much information available on it, so much whatever, people still go like, it's not going to happen to me. Those commercials on TV with like the trachs, and I have to talk like this with like, oh, that's, ooh, poor lady, oops, unlucky. No, not unlucky. It is prevalent. It is something, those carcinogenic chemicals that are coming from cigarettes and the vapes and whatever, and also are affecting you. Okay, nutrition though, back to that. Did you know that physicians get about 4 hours of nutritional education integrated into their entire programs. It's like 0. And yet again, poor nutrition is the #1 contributing factor to what ails us as a nation. And the prevalence of fast food, right? The worst food is what? The cheapest. Absolutely. The worst food is the cheapest. So there is definitely even a bigger systemic problem, right, of affordability of food that is good and that is nutritious and that won't cause issues. But you know, who can afford eating organic all the time and so on and so forth? Plus again, our relationship with food in this nation is not great, right? Steak for breakfast, steak for lunch, steak for dinner, in whatever, you know. I mean, the steak for breakfast probably looks like sausage, but still, you know, whatever red meat, bring it on, bring on the meats. Arby's, right? They've got it. The meats, that is. All right, what else? So, poor lifestyles or unhealthy lifestyles. What else? Sedentary lifestyles, right? We don't move. Just the nature of work nowadays is such that we just don't move, right? And as nurses, you probably will move after you're done with studying, because that's like a lot of, you know, not moving. But yeah, vast majority of work now is sedentary. So that obviously contributes to it, and we don't do anything or don't do a lot away from work. And then we come from work or from school and plop ourselves in front of the TV, right? Ooh, yeah, how many subscriptions you got? Hulu, Netflix, Disney Plus, Discovery. Ooh, there's Magnolia Network on it now. Yay. You know, HGTV? Constantly. So our relationship with television isn't healthy at all. And it contributes to, you know, just fascinating. Okay, what else? What else? Right. So that is true, right? Ever seen those commercials and we still advertise it on TV? Ask your doctor. It's like, of course I want to twirl in the fields like she is twirling in that commercial. Must have that particular pill. And then, you know, they're like in very fast kind of disclaimer manner. They go, yeah, severe diarrhea is just the beginning of what you're going to be experiencing while twirling in the fields. And then obviously death is, you know, oopsie, the unlucky ones, right? Yeah, and our, as we discussed earlier, our fix for everything is like we completely disregard the stuff that is preventable or kind of stuff that promotes health in the first place, like movement, like proper nutrition, and all of this, and then we also always have this thing in the back of our minds. Okay, if something goes wrong and it's going to get fixed, you know, I'm going to get a pill for it, and we go into the doctor's office and we like stomp our foot, and you know, my mother like, you know, Mom, that's a virus. Antibiotic is not going to help. She's mad at her doctor that her doctor is refusing to give her antibiotic. So she has a good doctor. The others just to get rid of you sooner. Like, okay, here you go. Just go. Here, take whatever you want. Rolling in a field for sure. Yes. Here. Why? The what? Right. So we're a society that contributes to this you know, overprotective. The physician's behavior is right. They're like, if they want it, I'll give it. going to err on the side of not getting sued. Why else? Do you see our physician availability? They don't have time at all to spend with you and well, you know, educating somebody on proper nutrition. That takes time. Lots of it. Yet they haven't been educated in the first place. So, and they don't have time. And that quick in and out, 2.5 minutes maybe, after you've waited for 45 on that, looking at the walls, and it's like, oh, maybe that pill. Because, there's a poster for it there. Anyway, so yeah, no time. Therefore, our relationship with prescriptions are not great. What else? What's contributing to this high spend and low outcomes? Right, chronic conditions that are preventable. Chronic conditions that are, first of all, preventable, but secondly, unmanaged, right? Again, as we said, most stuff that ends up in acute care is poorly managed chronic conditions. And who's responsible for managing chronic conditions? The individual, yeah. Here they are sitting in front of a TV managing their chronic condition. Look, people don't have enough knowledge, first of all, to manage it. And then again, there is some patient education that perhaps happens, but some people choose not to follow the whatever directions are given. But nobody follows up, right? There's not a buddy that you have that, a nurse perhaps, that would be there all the time and check in with you all the time. Ever heard of Laylar around here in the college? Yeah, because we know what ails you as learners. And so we're like, they're on your case, It's like, hey, remember me? Let's talk about what your needs are and so on, and guiding you through it. A similar thing would be to effectively manage chronic conditions would be needed. Okay, so that poorly managed chronic conditions. What else? Come on. All right, I'll give it to you. So we talked about the lifestyles, inadequate health promotion, preventable, poorly managed chronic conditions. The system itself we mentioned before as well, right? So the system was built right after the acute care system, the way we have it now, and have perpetuated over the decades after the World War II, was built to truly address the acute problems. What were acute problems back then? Injuries, right, a bunch of injuries. The post-World War II population was younger. Ever heard of baby boom? Right? Everybody came back and it's like, let's make some babies, yay. And they did. And those babies were very, kind of like a rebel generation of their time. And all sorts of injuries and all sorts of, things that are, what else? The baby boom itself, right? That's an acute problem. It's like a problem that lasts for, kind of chronically for 9 months or so. And then boom, acute. It happens. So, you have to address it. You have to have facilities and so on to be able to support childbirth and all of that. Okay, so the system is inadequate for today, dominated by acute care. We're not focused at all. There are some systems that do some insurance carriers, for example, like Kaiser Permanente. They are a very large carrier in the West and specifically in California. And so because they're a kind of all-inclusive self-insured provider and payor, right? It's obviously in their best interest to spend not a lot, and so they do a lot. They shift a lot of care into this preventative and chronic conditions management and promotion of health and so on and so forth in order for it to make sense financially. So yeah, most everybody else is again completely reactive, right? We don't go to the doctor unless something happens, right? It's that relationship. It's not the proactive relationship with any healthcare provider. We don't go just to like, oh, let's make sure nothing happens in the first place. That's why I'm here. You know, physicals we have to drag people to. Right? So colon cancer, for example, and this is one of those examples. Colon cancer, 100% preventable. Is the number 2 cause of death, number 2 preventable cause of death. Colon cancer. How do we prevent that from happening? Screening. Starting earlier. The age was just moved up to 40, I believe, or 45 or something like that, where it used to be 50. So, because more and more younger people are getting it now. Why? So why more colon cancer? Well, screening, yeah, but in the first place, so the screening could prevent it. What's lifestyle? Exactly. So that contributes to the formation and everything that we ingest. You know, yay, Coca-Cola is happiness. That, you know, is there? I don't know if Coca-Cola causes polyps, and you know where. Perhaps it's a chemical. Nobody knows what's in it. Everybody drinks because it's happiness. But screening is absent, right? And women do better than men. Like, oh no, not near my butt. No doctor comes there. Rather have a colostomy, you know. Like in a good, that's a good outcome. That prolongs life. The worst outcome is dead after it's, you know, but the periodic screenings and removal of polyps, if there are any, prevents those polyps turning cancerous. And it's a long process for them to do that. So yeah, it's again reactive. We don't pay attention. Remember how much employers paid? A chunk. Yeah, through the insurance plans, 1.2 trillion, private insurance, employer sponsored. Yet they do nothing to tell you, hey, if you have better health, if you weller, you'll pay less, or we'll incentivize you some other way. They're absolutely disengaged. They keep dishing out, you know, 7-8% increases, and obviously passing on in premium payments as well to their workforces. But it's a very passive. Okay, whatever it costs, I guess I have to pay. I'm required to do that, and I have to attract people to work for me, and therefore I'm going to do it. And yet nothing is being done to use that money more smartly, right? Nothing. At Nightingale, we're different. We're you know, just hired what we call the Wellevator. There's this manager in our human resources that is, you know, and the programs have existed now for several years, but that's going to drive our collaborators' health and faculty health forward and up and prevent stuff from happening in the first place because it is cheaper. That's the point. Prevention is not sexy, you know. It's not like all the drips. Oh. Ooh, I see you adjust. Ooh. Right. They are terrified for not a good reason, because employers don't have access to that information. It's protected by HIPAA. It's third-party administrators that do that with insurance companies and all of that, and you know, and the employer gets the verdict. It's like, your people did well, or your people suck, you know, and therefore here is the bill. So that, yeah, but you know, again, we're misinformed as well on a lot of stuff. Inability to access care. We've talked about that, right? So who has access? Who has like free access to care in this country? The wealthy. They're generally healthier much healthier than those who are poor. Systemic? Mm-hmm. Absolutely. So access is, there are cost-related access problems. There is geography-related access problems, right? People in urban centers have better access than people in rural communities. Everybody can understand that because of just nobody's available. Practitioners are not there. So that's a systemic problem. So this geographic, and then there's demographic access issues. There's studies that really, and look, there's not too long ago, I don't remember which, several medical schools, the students were asked whether they thought that black people would experience pain in any different way, and they were like, oh yeah, they don't feel as much pain because the skin is thicker. That was medical students in this nation. Like somehow saying, and there's studies that further black women really suffer with this. The going to a doctor and saying, I am in pain. They're not trusted, right? You're here to get some drugs. You're not here to, and so it goes, so pain goes chronically untreated and then self-treated and self-medicated and all of this. So it is, the issues are systemic, the issues are huge, and the issues have to be addressed. And then this last one, primary care provider shortages. There is, as we already talked about, there's not enough primary care physicians. There's not enough FNPs. By the way, shameless plug, we are in the process of approving our FNP program, and so and with hopes to roll it out in the spring. And very excited about that because again, there's not enough. But also, not even at the FNP level, but on a community health level, nurses, the grads, you guys, after you get licensed, do not choose to go and work in community settings. And working in community settings, that's what would allow then better population health management. So that, and that is an issue. And the reason people don't go is because most of what everybody learns in nursing school is acute care, right? That's what people are comfortable with after graduating. And again, because that front end, the prevention end, the chronic condition management end, never even mentioned in some schools. And so, or in many throughout the country. Plus all of the projections now to 2030, 2035, I forget which one, the last one. It constantly remains at about 1 million short in the next decade to 15 years, 1 million, for us to be able to truly address population health everywhere. So it is, the issues are great. And these are the factors that affect high spending. Unnecessary care. Remember that? Give me the pill or else. Yeah, that's part of that. So prescriptions, overprescribing is there. We pay for services, we don't pay for performance in our healthcare system. Meaning, whatever outcome you got, whatever, we'll pay you for what you performed, right? That's why kick them out of the hospital. We've done the procedure, we got paid. Yay! Whether it worked or not, not our issue. So that is a big problem. Unnecessary diagnostics, right? Oh, WebMD told me I'm suffering from this. Therefore, scan me fully. Because, so, and we do. Our prevalence of unnecessary diagnostics is high. Lack of care coordination, right? No providers talk to each other and kind of connect. Nothing is connected. So a patient or just a human who needs access and has access still is left to navigate the system themselves, right? And as Google, what to do next, rather than somebody there coordinating that care for them, and saying, you know, yeah, probably proctologist is not the right thing right now. How about we don't start there, or nephrologist, or whoever it is. And yet, you know, I have this, I'm feeling something, I am going to go, if I have access, and I have a very low copay, I will go to everybody, only to find out it was a cold in the first place. Okay, litigious society, we mentioned that. Provider shortages, again. Administrative costs, that's quite high. Did I have that slide? Oh, where? Oh, no, I don't. So our I'm probably going to lie to you, but just visually trying to remember the number. It's about 295 billion or so that go into administrative costs of healthcare. So a very large number, once again. We spend on administrative kind of billing and paperwork processing and all of this the most of anybody. Why? Why do we spend the most on that in this country, as compared to that rest of the group that gets better outcomes and spends less? Not necessarily. We don't necessarily see more patients. Multiple providers negotiate and establish processes and paperwork and all of this with multiple payors, right? Many payors, from Medicare to Medicaid to this insurance company to that one, to that one, to that one. So, and every single provider has to, in that community, has to make sure that they have negotiated and have done, you know, that the processes and systems are established between all of them. So that takes a lot of time and a lot of money in order to be able to coordinate all of that administratively. So why don't others spend as much? Well, what are they doing if they're not doing what we're doing? It's not necessarily socialized, no. Not all of them have socialized medicine. But what do they have? They have universal systems. Means everybody's included, everybody pays, everybody has access, and then there is a single payor. That's the system. And again, we have a single payor system just for older folks. It's called Medicare. And then everybody else is not included. And then every single time we start talking about that, politically it's a non-starter in this country. For no good reason. Because we already are paying. Ta-da. That's what I think most of the population just doesn't understand. Is that it already is coming out of our pockets. It's already is taken. It's already is paid. And if we had a better coordinated system and better access, we would be getting better outcomes for what we pay. Already. Well, if you put it that way, I'll think about it. Ponder it. Just ponder it. Yeah, that is the biggest difference between all of those other countries. Every single one on the list has universal health. Now, they're not all socialized, meaning they're not all provided by the government. The services are provided by many different providers that are private providers. And you know, there's the difference, again, is that coverage is universal and payor is one. But you know, the providers are many. and they don't belong to the government. In some countries they do. In many of countries they don't. Socialized, belonging to the government. They provide the services themselves, rather than just who pays, who signs the check at the end of the day and sends it to the provider. That's the difference. And again, I think the general population understanding of how that works isn't quite there. If we think single payor, we right away go like, oh my goodness, we're getting into socialism. No, we're not. No, we're not. So that's the big difference. Oh, yeah, I don't know. It was like, if you remember, this is probably 10 years ago, maybe whatever, when just early into the Affordable Care Act and all of this, and there were all these demonstrations, and some of the signs were like, "Government, hands off my Medicare." I mean, that's people were like walking around with like asking the government to take their hands off their Medicare. Yay! Well, newsflash, Medicare is government. So anyway, yay! A lot of education is needed on all different fronts in this country, right, about the healthcare system. Now, the sad part of it is that what you're getting here at Nightingale, the vast majority of, I mean, there are probably a handful of schools out of thousands and thousands and thousands of nursing programs in the country that even talk about this, any of this that we're describing today. So that call, when you look at the very first slide, when you get it, remember when like achieving health equity and the power of the nurse to achieve the health equity, that very first thing that I showed you, and you will see that education is mentioned in #1 position. Education for nurses is mentioned in #1 position in order to start evolving and changing the system. Like what you learn, why you learn it, how you learn, like where you go to engage in your SOFIs, right? The on-ground components is important. It's not all going to be in acute. It shouldn't be, because that's not where you need it, really. This is not what the nation needs in order to solve its chronic issues of overspending and underperforming in the system. Anyway, consumers. We're overly optimistic, right? We already talked about that. That's not going to happen to me. When I see, or a scary picture on a pack of cigarettes or whatever else, or another steak, like, oh, it's not getting clogged at all. At all! Everything is great in there. Or like a little more ketchup and salt and whatever else on yummy. Yeah, you take sugar, salt, and lard, and you mix it together, and it's delicious. It is. Because that's what our taste buds respond to the most. Sugar, salt, and lard. Fat. Carrots. Ugh. I think I'm going to die if I eat a carrot. So that lack of effective health education, we talked about that, right? Like there's nobody out there educating the populace, educating their communities. That's why in your communities, that is exactly where you need it, to educate the population. And again, do it through Facebook. I don't know, like somehow drive evidence stuff into your community, however you connect it to your community. And again, if you're only individually as a nurse, would only be responsible for 99 other people, part of which, a lot of whom are actually your family or like the next level of family or whatever else, ta-da! Right? Unless the whole family is nurses, then you go further out into the community. But it's possible. Is just, again, our commitment to it, what at the end of the day has to matter and has to be there. We as nurses have to commit to healthier population. We as nurses have to commit to more population education. We as nurses have to commit to all of that. We have to commit to getting, I know NICU is so sexy, oh babies, Oh, preemies. Oh, yay. That's what I love. 60% of all incoming classes are like, I'm going to work in NICU. No, you won't. We don't need you there. There's plenty. Find another passion other than preemies. And drive it in. And most of you should be finding passion in chronic conditions management, because that is what, at the end of the day, that's like the fastest thing to slowing down the spending, is to start managing. We already have those conditions. That will remain for decades to come until, and then slowly, because you have to start early on with children, right? And educating them into the healthier lifestyle and doing all of that in order then for it to pay off in a longer term. So these numbers that we're seeing with prevalence of chronic conditions, 28% with multiple, 28% of the population, that will continue, and it will continue climbing, because it's too late for many. So we have to focus on that while working with younger generations to get them to better health in the first place. So that's that's there. The no comparative shopping, right? Those who have insurance. So some people don't have access, as we discussed at all, to healthcare services, and others with insurance, especially with cheap copays, right? Oh, it's $10. I'm gonna go and like prescriptions, $10. I'm gonna go and I'm gonna use all of it, everything. Give it to me, and I don't care how much it costs the insurance company or how much it costs my employer. I don't care, because for me it's $10. I can do it. Now, all of you shop on Amazon? Probably. Yeah. And if something is like 37 cents less from another person that is selling it there, oh yeah, I'm getting the thing that 37 cents less for the same thing, So we understand as consumers comparative shopping and price comparison and all of this, yet we don't ever realize of how much price differentiation exists in healthcare services. Several years ago, I had an issue with my shoulder, and I comparatively shopped for an MRI. And so with contrast and injecting and all of the good stuff, the X-rays prior to that for the injections and all of this. So I had it. I paid about like $459, something like that, probably less than $500 total. Some of the pricing that I saw, providers right down the street were $3,000 for the same thing. And that happens day in, day out, day in, day out. Same services at the same level of quality are provided at very different pricing. And so again, and as consumers, we're not educated. As nurses, we have no idea. When we work, for whomever we work out there, we don't know what is being charged for the services that we provide, right? We waste, too, a lot of, oh, I don't have a notepad. Let me pierce this 2x2, which is sterile, with a pen, which makes it unusable, obviously. And it's much more expensive than a piece of paper out of a notepad. Okay, sedentary lifestyles, we discussed all of this. So now, finally, we're going to talk about, you're going to tell me what it is that we should be doing. And we've mentioned all of it, or a lot of it already, but I just want to summarize and to get you guys into that. This is what we can do. Okay, you need to be educating the communities. Good, that's good. In order to educate the communities, what needs to happen prior to that? For you to be effective in educating your community. The what? Yeah, thank you. You have to know your stuff. Not from talking heads on TV, but actual research, science, evidence stuff. Peer-reviewed journals, all of that will get you, going on this. Catherine, as a librarian, is there to help you to figure things out. Evidence on the internet is not evidence, unless, it depends on the source of it. So that's important. You absolutely have to know your stuff. And here's what I have to tell you. Yes, you can pass a course with a C+, I think, in nursing. The last I checked. 75%, something like that. Okay. Do you think 75% of achievement of your learning and the outcome is enough for you to know your stuff and be effective? Absolutely not. It is absolutely not. So you may pass here, but your effectiveness as a practitioner later on depends on whether or not you know all of it. And whether or not you can reason through all of it, not just a part of it. That is important. You will never, and again, as a profession, I know we're, we're the most trusted profession, and we're like, yeah, look at us winning. No, we're not. If you really truly look at our outcomes, we're not winning. We are the largest healthcare profession in the United States. The largest. And yet, we look at ourselves as, oh, well, we have nothing to do with the outcomes. The outcomes and the spending and all of that somehow happens without our involvement. Well, I have news for you. We absolutely are involved in creating the outcomes that we're getting as a profession, collectively. If all of a sudden 4 million of us knew our stuff and were fully educated on how all of this comes about, the health outcomes and what we spend and all of that thing, and then made the commitment to changing that, wow, the outcomes would be very different, very different. And what the, again, National Academy of Medicine says is that unless nurses do, plus some policy changes around what we are allowed to do and, and stop, some states, like prevent us from practicing to the full extent of our skills and knowledge, theoretical full extent. Because again, some of us do and some of us don't. Go figure why. Nobody asks you for your transcript when you get a job. Maybe they should. Like, yay, all A's, I'll hire you. No, because there's a shortage, nobody cares. Right? They just need a body to plug in. But again, your effectiveness depends on whether or not you know it. So again, if we started doing something systemically, as a profession, started doing something different, committing to different things, figuring out different stuff, approaching the population in a different way, we would have better outcomes already, and we don't. So it's very important. Now, plus another thing too, why do you think we're not allowed to practice sometimes, even at like nurse practitioner education? Why aren't we allowed to practice to the full extent of our skills and knowledge in some states, some places? Who's responsible for that? The doctors are responsible for that. Yeah. So there's this ongoing battle of turf battle of them protecting the turf. And it's like there's so much turf, it doesn't need to be protected. We just need as many providers as possible, like pulling in the right direction. But their number one argument is that we're dummies. And they have gone to school for this long, and they have done all of this for such a long time, and they are the specialists, and they're all of this, and they use really good examples of when we're absolutely ineffective because we don't know. Because somehow that day I missed in school. Yet I managed to pass, and then I managed to show minimal NCLEX is the minimum. minimum passing that thing. It measures the absolute baseline safety and reasoning, the baseline. Passing NCLEX is not enough to be effective in your practice. And yet, again, if you only gotten 75% throughout your education, you will never pass NCLEX. Yay, because you know, NCLEX is what stands between you and the practice. And we definitely would like to protect the population from anybody who doesn't have the requisite knowledge and reasoning and skills and all of that and basic safety. So I cannot tell you enough how important this is. And I, in new learner orientation, right? We talked as I was here with you, not here, but the other place. We talked about that focusing and really rearranging. Some of you have to, in order to know your stuff, in order to show up in any healthcare setting and be like, you know what, I'm a nurse, hear me roar, because I know my stuff and I can be very effective and I will be very effective in all of this. That requires sometimes unsubscribing from Hulu. I'm sorry, Hulu will just have to cry for you. I don't know what that handmaid is going to do without you, without you watching her constantly. Trust me, the actress will make as much money. So don't worry about her. Worry about you and worry about what you learn and how you learn and the fact that after you're done that you come out and you're effective. So that's a very important part in the solution of this. What else? What else? In order for us as the nursing profession to solve these issues, what else has to happen? So we have to educate the population. In order to do that, we need to know our stuff in order to be effective in whatever practice we go into. What else? Come on. Right, we have to innovate. Go, tell me more about that.
We have to, because the physicians aren't actually on our floor as nurses, we're bedside. We're more involved in patient care, so we have to innovate what we can do better, how we can save money, how we can prevent patients from coming back. We have to communicate. We have to just educate.
Right. So all sorts of stuff. In the, I don't know if we have it in the generic program. I think we do. There's this like capstone project that you do. I know for sure RN to BSN we have it, and maybe I don't know everything, right? But there is. I think you guys will be going through a capstone project for either your employer or community. There's some kind of, and it's all about innovating, right? Of how we address, because in order to reach the population, right? Even with education, we have to innovate of how that's happening, because right now whatever we're doing, if we're doing anything, isn't that effective. So have to tweak and change the approach, essentially, and in many things we can be less wasteful, we can be more effective in any setting by changing systems and processes that are in place. Okay, what else? What can nurses do? How can nurses change public policy? Laws, regulations that sometimes prevent us from practicing to the full extent of our skills and knowledge. Advocate for change is good. First, you know your stuff, right? That's like number one. You have to be credible. Two, you start advocating. How? Yeah, so that's good. That gives you more credibility, right? Continuing your education, pushing ourselves to get to higher level of degree attainment, hence knowledge attainment and reasoning attainment and all of this. help with that credibility, building the credibility. And then after you have that, how do you advocate? How do you actually change public policy? What needs to happen with nursing in order for us to be effective in changing public policy? Who creates public policy? Who writes laws? Legislatures, lawmakers write laws. Guess how many nurses there are in the US Congress? Yes. Correct. Guess how many nurses there are at the US Healthcare Department in leadership roles? I don't know if that even is still true or not, because the administration is changing. And so, and we're like, yay, let's wait and see if somebody will do it for us. I have news for you. No, nobody will. It's ours to own, ours to push forward, ours to do. We have a lot of stuff to do. And again, I'm talking we. I know you guys are not quite there yet, but commit to it now. Like, I will do this. I will be the change that I want to see. That being change that you want to see. Let's talk about that. What? If you want your population or your community or your patients, whatever, to be healthier, what do you have to do? You have to lead by example, because if you're standing there and puffing in front of the hospital entrance and then your patient passes by and it's like, oh gosh, they went to school for, a long time. Must be nothing. All of that is just a big propaganda lie on TV. Or you reek of cigarette smoke or whatever it may be, or your weight is not there. Or anything else, or you sit all the time, or you will never become effective in changing somebody else's health or guiding somebody else's in facilitating that unless you have been able to do that. That is important, right? It's as important and so this is really whatever ails you personally. You have to address that head on, and you have to learn how to. And then after you go through that, you become so much more effective in leading other people through it, through those needed changes, through, as tough as behavioral change is tough. It's really, really tough. And so, but you become much more effective if you can be the shining example of it, the model of it. What else? What else? Yes, Ben.
Some of the students in the chat are saying Mikhail for Congress.
Oh, great, Schneider for Senate. That's what I always say. Representing the great state of Utah at some point, as soon as one of those two guys move aside. Maybe I'll move to Idaho and then do it from here. Anyway, so what else? In health equity, achievement of health equity. What else is like one important thing that we have not mentioned? That is absolutely health equity is not going to be achieved unless that happens. What does nursing population look like? Well, the shortage, is there. What does it look like? The what? It is largely female, correct. It is only about 12% of nurses are men. How are we doing in the population with proportions? 88% women and then 12% men? Ooh, they'd be so popular. No, it's about a 50-50 split. A little bit higher on the females, right? But about a 50-50 split. Yet the profession is largely female. Now, women are not, just because certain things are just, women are more effective with women in that guidance. Imagine if there's a bunch of guys who are out there saying, nothing wrong with getting that colonoscopy. I've done it. Not that, big of a deal. You fart a bit afterwards and you're good. Yay. And a painful death is prevented. So again, there's that. What else? What else? What else does the profession look? How does it look? 80% of it is white. 80% of it is white. Now, is 80% of our population in the United States white? No, nowhere near that. So it is an issue, and it's been shown time and time again in studies over and over and over again that the better the workforce that the practitioner, the provider workforce reflects demographically and socioeconomically, reflects the population that they serve, the better the outcomes, the cheaper the care. Time and time again and time again. And yet, 75, so that's the number, 75% of all nurses in the United States are white females. We have a long way to go. How do we change that? That's a great question. I love that, curiosity. How do we change that? Thoughts, ideas. How do we change that? What has to change first? Already given you the answer before. And when you look at the first slide, it's going to be the number one thing. Education. Education needs to change. Diverse populations must have access to nursing education. And public policy has to change in order for that to happen. Or Nightingale College has to become like the dominant force. Over 50% of our learner population in the baccalaureate program, people of color. I'm not doing that great on men yet, but trying to figure out how to increase that as well. So, and that is because this guy that knows his stuff and is pretty credible and all of this decided, hey, we're going to do something different. We're going to do things differently. We're not going to, go and only admit people who are, when the best schools, high schools or whatever, cream of the crop, only A's. We're going to allow other people to have a chance, right? And because we believe that if you make a commitment to it as a human being, right, as a learner, you can do it. You actually can do it. You have all of the capacity in the world, no matter what you look like, no matter where you come from, no matter where you live. You have all potential in the world to be amazing. Amazing. It just takes a lot of work. It does. Like this didn't arrive here in this way. At some point in my life, I was a mess. 35 pounds more than what you see now, a smoker, and that's just the beginning of it. Until I finally, said, okay, Mikhail, snap out of it. Commit to better you, and then drive better into everywhere else. So that is important. And that I cannot stress it enough. Look, we can sit there and wait, or those who do pray for miracles. But that's not going to be enough. Until we are able to unleash our human potential. Through Maslow, through that thing, right? Sleep is important. I know you have a lot on your plates. But if you're not getting 7 to 9 hours, depending, and it varies for each adult, 7 to 9 hours of sleep every night, you cannot be effective. Your cognitive ability just doesn't go at you're not functioning at your cognitive peak. If you're not eating the right things, you're not functioning at your cognitive peak. And it's at your cognitive peak where things just happen, learning just happens. It's just like, oh yeah, I get it. So it's not only as, kind of as simple as canceling Hulu. There's all sorts of other things that have to be happening in order for you to be that effective. And we have to become that effective, like no exception, if we are to change this system. And this system needs change. Like, I am tired to live in a world of unhealth. Just tired. I am tired of paying so much and getting, and trust me, I do. Because, like, I'm not poor. But I'm tired of not getting the outcomes that I want to see for that, what I pay into the system. Tired of it. So again, I decided this was the way to address it. I, as an individual human being. This Nightingale College thing, that's my answer to this is what I could do. Every one of you has the power to do something absolutely incredibly amazing for your community to begin with, your family, you to begin with, and then your family, and then your community. You just have to know your stuff. You have to be credible. You have to commit to it. You have to drive at it. I mean, and it's not, again, it's tough. It's just like there's no shortcuts to any of it. That's the point, right? If we want to see better, we have to be better. That's simple. That evolvitude thing that we talked about at New Learner Orientation, refer to it, the new catalog, the whole new academic year of publications coming out in a couple of weeks. It's going to be still there. Refer to it every once in a while. If you want to see a kinder world around you, be kinder. If you want to see a more forgiving world around you, be forgiving, right? Be the change that you want to see. If you want to see a healthier community around you, be healthier to begin with, and then you can do other things. So that is absolutely incredibly important. And yes, we as nurses have to get into public office. We do, whether it's the U.S. Congress or community-based. We as nurses have to be on hospital boards and healthcare organization boards, governing boards. Very few of us have the voice that we can use then to drive change into the communities, again, into the healthcare system. Very few. That is sad, sad. There's way more doctors on those bodies that matter, whether it's legislative or whether it's governance, community hospital boards, so on and so forth. So it is, again, and I just have to do it. Just do. Nike said just do it. So I think we should just do it. Other things. Come on. Talked about nursing education needs to be strengthened. Talked about the, public policy. What else? Anything? Advocating. Joining nursing associations to advocate. Uniting nursing associations across this country. Sometimes we pull, we're kind of in these groups that pull in different directions. Woo. So a lot of work to be done. And this responsibility is ours. If nothing else you carry out of it, is that it is yours. It is truly yours. All of you out there. I alone cannot pull it. None of us. But if we start, deliberately and systematically addressing the issues that exist, then we'll be able to succeed. Eventually, it is a long road, but hopefully, you're ready for it, and hopefully, look, Are you fired up at all about this? Because like every time, I do this every semester, and I get like fired up about it. Yeah, we can. Yes, we can. Yes, we should. Yes, we will. It is up to you and each and every one of us individually, whether these huge issues that we have as a country are going to improve and change and whatever. And again, going to the ballot box every once in a while and then just bitching at TV, that's not gonna work. That is not gonna work. Other things, and there's plenty of examples that we've talked about. So, and this well-being actually of you as a nurse is part of the National Academy of Medicine recommendation. We have to be well in order to start being more effective than what we are now. Because as a profession, we are unwell. We reflect the population pretty well. Or maybe it's the population that reflects us pretty well. So again, up to you to make that decision, up to you to do it. I'll read this as the, and anything else, by the way. And again, as I said, all of this is going to be sent to you, both the slides and the Future of Nursing report with all of the supporting documentation. And so please review. And there is going to be, I think in your last semester, there's going to be another assignment that surrounds this, but you just write it out. And make sure that you use updated information when that happens, right? Because like a couple of years from now, there's going to be new data. So use the latest data. But the sources, all the sources of the data are on the slides, and then you can find it. You can find the latest and the greatest. So this is the concluding remarks from the Future of Nursing report. Nurses are bridge builders and collaborators who engage and connect with people, communities, and organizations to promote health and well-being. That's who they are. This is who we are. This is the new definition of the nurse. Bridge builders and collaborators connect with people, communities, organizations to promote health and well-being through all the different things. They need ongoing support from systems that educate, train, employ, and enable nurses to advance health equity. The COVID-19 pandemic has starkly revealed the challenges nurses face every day and has added significant new challenges. It has also given some nurses more autonomy, shifted payment models, and sparked overdue conversations about dismantling racism in healthcare. Policymakers and system leaders should seize this moment to support, strengthen, and transform the largest segment of the health workforce so nurses can help chart our country's course to good health and well-being for all. And that's exactly what we need, good health and well-being for all. I came to the States as a refugee almost 30 years ago, seeking that, seeking justice for me, but also remembering that I then built and am responsible for building justice for all. And so, and I cannot think of a better profession to do it in than nursing. Baratunde Thurston, I'll close with this, said, justice is love, live out loud. So go do justice, build justice, create justice for all by being the most loving individual you can be to everybody. So thank you all here for coming and engaging with me. Thank you all out there. We'll send you all of the info. And
Just real quick, we'd love for us to be able to just take a quick picture with all of you guys.
Okay. Other than that, everybody out there in the cyberland, thank you. Good luck with your studies. Remember, 75% is not enough.
They'd like a monthly pep talk from you. Monthly pep talk.
A monthly pep talk, all right. I'll be, yeah, I've actually been told that. We do have communications people now that can record this, and I'll send you a thought of the month, an inspirational thought of the month. How about that? I'm committing to that. We'll do. All right. Well, thank you. I got to catch a flight, but we'll take a picture. Yeah, okay.
And then I have parking for all of you as well. Where do you want to do it, Ben?
Oh, I guess we'll just do it on that side wall over there. Over there.
With Miguel. With Miguel. Alright.
Although, if you don't mind, I want to post it to like our Facebook or Instagram. So if you don't want to be on Facebook or Instagram, you don't have to be in the picture.